very high impact journals. And I think he probably has a couple of maybe more than 2 articles in Lancet every year. So he's a very researcher with high impact, and he's brought all his wealth into this particular course. We've been really fortunate. Thank you so much, Dr. Dennis, for having been with us throughout the last 6 months. We're also happy for all the faculty members from across the country who helped with the training program. Maybe I would have more opportunities to individually thank them all during the valedictory on the 17th October. Today, we are happy to have 4 judges. I mean, they have been, the way the program works, Dr. Dennis will explain, but we have 4 judges who will be part of the proceedings today. We have with us the Professor PSVN Sharma, who has been a professor at Kasturba Medical College for many years. Many of us in South Zone know him very well. He's very popular for the psychiatry updates that he conducts every year in his college. He has had great interest in psychiatric rehabilitation and geriatrics mental health. Thank you so much, Dr. Sharma, for joining us. I would let Dr. Dennis, when he takes up the proceedings, he'll probably call upon you to speak for a few 15 to 30 seconds as he you will have an opportunity to comment on the research later on in the program. We also have with us another senior professor who has recently gone after completing her tenure, gone into practice in Hyderabad, Professor Gauri Devi. We have had a great opportunity to share many both academic fora and also examinerships with her. Thank you so much for joining us, Dr. Gauri Devi. She has been particularly, since her specific interest is more in the area of child psychiatry, we have all the more occasions to interact with each other. Thank you for joining us at short notice. Welcome, Dr. Gauri. You're muted, Dr. Gauri. Yeah. And we also have Professor Vikas Menon, Professor of Psychiatry from JIPMA, Pondicherry. He was one of the judges when we had the journal club discussion some time back. He is well known to all of us, not just South Zone, across the country. And his area of interest is quite vast. It's consultation liaison secretary with special interest in suicide research. And thank you again for joining us today in this program. And hope you have been with them when they actually were learning to do the research methods. You'll probably see some outcomes of all that learning today. Thank you, Dr. Vikas.
Thank you, sir.
And pleasure to invite Dr. Christina George, Professor of Psychiatry at Somerville CSI Medical College, Karakonam in Kerala. She also agreed at very short notice. Thank you, Dr. Christina, for joining us. Again, with Dr. Christina, I have shared some examinership roles, and I've been fortunate to hear her presentations in many psychiatric society meetings. Thank you for joining us, Dr. Christina.
Thank you. Thank you.
So with this introduction to the judges, I hand over the proceedings to Dr. Dennis, who in his inimitable style will take us through how the proceedings will run today. A special welcome to Dr. Rama, who is one of the faculty for the programs, and she's been an inspiring presence in all the sessions. And Dr. Mohan Raj, who has been the enthusiastic supporter of this program. Over to you, Dr. Dennis.
Right. Thank you very much, Dr. Ashok, and good evening, everyone. And my first job is to welcome everybody into the meeting room. There are still many people in the corridors. So please come inside, take off your mask, sit down, take a seat, feel comfortable. So that's a long way of saying, please put on videos wherever possible. Dr. Sharma, particularly, I mean, I've not seen you, sir. It would be nice if you could have your video on. Right. Excellent. Thank you. Thank you so much. Good. Some more people, please come into the classroom. Please come into the auditorium, or whatever we want to say. I'm trying to invent new ways of getting people to put their videos on. Okay, so let's get started. I can't believe we've been together for 20 or a little more than 20 weeks now. So, and on average, our sessions have been 2.5 hours. Some sessions went beyond 3 hours. So if it is on average 2.5 hours, we have been with each other for 50 hours within this frame of the computer screen, or right. And it's been fun. It's been fun. And as Dr. Ashok said, this is the culmination of all that we discussed and learned since April. So, and today you're going to present the fruits of your hard labor. Hard labor was firstly sitting and listening through all of this, clarifying your doubts, and then working in your small groups to get the projects up and running. So today is going to be really, really fascinating for all of us. So now here are the procedures. And so firstly, I have this magic ball over here. So today group A and D as in Delhi, will be presenting, correct? So is D presenting first or A presenting first? This ball will decide. So today itself, we will decide even for next week, right? So we don't have to worry about what will happen.
A day after tomorrow, Dr. Dennis.
Oh, yeah. Just on Sunday, in a few days from now, a couple of days from now. So we'll decide that. That's step number one. Step number two is you have already decided from your groups who will present. So straight away, without wasting any time, we will start off the presentation. And here is how we will go. So you have a maximum of 20 minutes, not 20 minutes and 5 seconds, but maximum of 20 minutes to present. We need a volunteer, Dr. Ashok, from the organizing team who will keep track of time, who will give us one warning at 15 minutes and the second warning at 19 minutes and the final warning at 20 minutes. And we have to stop. It's a hard stop. Now we are serious. All these days we had fun learning, but today is going to be serious learning, wherein it's competition mode now. Right, it's competition mode, and you have to. So therefore, you don't get a second more than 20 minutes to present. Right now, the judges have been given a sheet of paper, and they're going to evaluate you. So let me tell you, I forgot to pull this out earlier. I'm going to score sheet. I'll just show you what we're going to. Okay. Give me a few seconds. It's it's here. I'll just pull it out so that we are clear on what the judges are going to score you on, and it is here. Right. Sorry, I should have pulled this up earlier. A few seconds. Okay, we are all done. Okay, so also from request to the judges. Okay, so this is the scoring sheet. So our judges, will request them to write the project design or the group name at least. So today it will be group A or D. So you will have to fill 2 sheets today. So here are the criteria for scoring. So how have they written and presented the rationale and need for the study, the research question and objectives, eligibility of the participants, the study procedures, how they plan to manage data, what are the statistics they're going to apply, is it the right one, is it feasible, ethical issues, public health importance, budget, there's 10 whole marks for budgets, really, really important. Quality of slides, how well did you prepare your slides, which is a team effort. Then this item number 8 is really an individual effort wherein you present and also manage time well. So for example, for some reason, if you not really kept pace with time and you realize at 15 minutes that, oh dear, you still have another 8 or 10 more minutes to go. So how are you going to manage your time? And then finally, handling questions and overall teamwork you'll be scored on. Now for questions, the presenter has to step back and the rest of the people in the team will have to step forward to answer questions. So I hope all of you have renamed yourselves along with your group name, which will help us. We request you all the time. If you have not done that, this is the right time to do it. So Sri Lakshmi, Raj Kiran, group A, fantastic. So we can see you really well. So either you write GRP, A, B, C, or D, or as Sri Lakshmi has written there, put it in bold brackets, capitals, your team number, or your name, A, B, C, or D. Right. That being said, this is what the judges will be scoring you out of. So I'll stop sharing this. I'm presuming the judges all have received a copy of this. It is a Word document, so you can even type it out into that. And then, towards the end, you need to write your name. The judges need to write their names and I mean, if you're just entering it on Word, it's okay. You don't have to bother about signing it. On the other hand, if you prefer to have taken a printout and you want to fill, please sign it, scan it, and send it to the organizing team. I'm sure Dr. Ashok has said whom to send it to. So please, if you could do it today itself, then it helps all of us. So that's a request to the judges for scoring. Right. So once the 20-minute presentation is done, the others, so let's assume A is going first. In this order, B, C, and D will ask one question each. So you have to have your video on, put your hand up. There is a way of raising your hand in the bottom, you can see. If you do that, even if there are 3 or 4 screens here, your name or your image will come up in the top left corner. So we'll call you out. So we have a nice system by which, so once your name is called out, you can ask a question. Now, how do you ask a question? 1 sentence or maximum 2 sentences question. Please don't ask very elaborate questions, in my experience, and all that is not needed. So one focused, okay, another, so that's the kind of question you ask. Second one is, what category of question should you ask? You must ask a methodological question, not a clinical question, right? You should ask a methodological question, starting from the objectives to your maybe your primary objectives, your sample size estimation, or how did you? So let's focus on research methods, not clinical psychiatry for today, right? So that's the focus question that you'll ask. So after we do 3 rounds of questions, depending on time, and then again, answers as well, crisp and short answers, please. Okay, and the judges will be pleasantly surprised by seeing how we interact with each other over here. So we've been practicing that as well over here on screen because we believe in a few things. So in addition to research methods, we've been discussing other things as well. Okay, so after we do that, it's the turn of the judges to ask questions. Again, the same criterion applies to the judges as well, which is 1 short, crisp question, 1 maximum 2 sentences long, right? After the round of questions are over, then it is time for the judges to clarify. In case, by the way, there is not going to be no back and forth question and answers. Suppose the question is as simple as this: what is the capital of India, capital city of India, or capital of India? Somebody said Bangalore. That's it. That person said Bangalore, we go ahead. So judges, please make a note. You have to come back and clarify that Bangalore is certainly not the capital of India. It is New Delhi. So that is clarification, right? Clarification. After clarification, you can teach both methodological teaching and any other methods you want, anything you want to clarify, please go ahead and teach everyone here. And also any clinical relevance that you found in the research project they did. And most importantly, judges, your third mandate, please, is words of encouragement, words of appreciation as well. That comes right at the end. Okay, I'm going to recap this very, very quickly. 20 minutes for presentation, 15 minutes warning, 19 minutes warning, 20 minutes hard stop. Then we have questions, short, crisp question from the other people. Please put up your hands quickly so that I will call out your name and then you can ask questions, short, crisp question. Similarly, short, crisp answer by people putting up the hand. The presenter can take a back seat and then the others can come forward and answer questions. And remember, you're being judged by the way in which you're answering questions as well. So the more people participate, judges give you more weightage. If the same person is coming again and again, doesn't sound so good. So it's a team effort. And in the end, again, the more variety in people coming and offering answers, more marks, which is the very last item, if you know, overall team effort, right? Then after the round of questions from the other teams, then the judges ask questions. Last step, judges to add value to this program. 1, clarification. Come back and tell New Delhi is the capital of India, not Bangalore, right? Number 1. Number 2, clarifications done. Then teaching, please teach whatever comes to your mind. So I'm sure the judges can make a note of a few things as people were speaking. So teaching both on methodological issues as well as clinical implications. And finally, mandate from the judges, request from the judges is some words of appreciation. I'm sure there is lots to appreciate. So at that time, you can feel free and explain. So we'll try and manage time as well as possible. So it is 7:24, 7:25. Let's get started. Here is our magic bowl. I'm going to give it a thing, and we open up. Oh, today A is going to go first. Obviously, D is going to go second. We don't have to open that to C. So let us see who's going to go first on the next day. So either B or C, isn't it? We'll see which is the next one that is coming up.
We also have E, Dr.
Fantastic. Look at this. So we're going in that order, A, B, C, D. Today is A and B, and Sunday is C and D. Do we have a fifth one, Dr. Ashok?
Yeah, we do. It's actually A and D today. Then Sunday it will start with C, and we need to resolve one of the other two.
So it starts with C. So why don't I, make another piece of paper rather quickly now, and we'll be all set. Here we go. That doesn't take too long. So I just need to write E. I forgot about E. How terrible. So let us see. So it's going to be either D or E that will be picked up from here. Okay. So right. So it is B. Okay, so it is going to be, so today it is A and D, correct? And then it is going to be B, C, no, sorry, C, B, E, C, B, E. Got it? Okay, so Sunday it is C, B, E. All right, now that we finished this, let's go ahead. Group A, please share your slides. And rest of y'all. Who's presenting from Group A, please?
I'm presenting, sir.
Okay, excellent. Smita is presenting an RCT. Dr. Smita, your time. Oh, sorry, Dr. Ashok, who's helping us with keeping track of time?
Bina is keeping track of time. Indu will also keep track.
I'll be keeping up, sir.
Okay, Bina. All right. Okay, your time starts now. Dr. Smita, go ahead.
Yeah, thank you, sir. Good evening, everyone. I will be presenting on behalf of Group A, that is the research buddies, the protocol on randomized controlled trial. These are the researchers of the research buddy. Sivasa, Varsha ma'am, Balasa, Endumati ma'am, Kiran, Ramya, and me, Smita. The title of our study is Baclofen versus Acamprosate for relapse prevention in patients with alcohol dependence, a double-blind randomized controlled trial. The need for the study. There is difficulty maintaining abstinence in patients with alcohol dependence syndrome. There are a limited number of anti-craving drugs. And there are very few studies on the effectiveness of baclofen as an anti-craving drug. Baclofen could provide to be a cost-effective option with better compliance rate, especially the once daily preparation. So the research question is baclofen as effective as acamprosate in reducing the risk of relapse over a period of 6 months in patients with alcohol dependence syndrome? The aim is to determine whether baclofen is as effective as acamprosate in reducing the risk of relapse over a period of 6 months in patients with alcohol dependence syndrome. Coming to the objectives. Our primary objective is to determine the effectiveness of baclofen compared to acamprosate in reducing the risk of relapse over 6 months. Our secondary objectives are to assess the level of craving in patients on baclofen compared with patients on acamprosate. And the second one is to compare the side effect profile and discontinuation of treatment between these two groups. The methods. Our study setting, this is a multi-center study planned in 4 centers across the 4 southern states of South India. The target population are all patients admitted for treatment of alcohol dependence in each center between January 2022 and December 2022. The centers that are included are general hospital teaching centers with psychiatry wards. Center A will be the sponsor and the coordinating center. That is, they will be responsible for the training as well as for the randomization. The study design is a double-blind randomized controlled non-inferiority trial. The inclusion criteria. Adults aged between 18 to 60 years, both males and females, with the diagnosis of alcohol dependence syndrome made according to ICD-10, admitted as inpatients for alcohol detoxification with the presence of a family carer to assist with the medication and the monitoring. The exclusion criteria includes severe renal, hepatic, and cardiac function impairment, dependence on other drugs except for nicotine, the use of other psychotropic medications except drugs used for detoxification, comorbid severe mental illnesses like schizophrenia or bipolar affective disorder, organic brain disease, and pregnant or breastfeeding women. The duration of the study is 18 months. The sample size, non-inferiority design with primary outcome of a dichotomous variable. If there is truly no difference between the standard and experimental treatment with a risk ratio of 0.14 in the standard treatment, then 504 participants, that is 252 per group, are required to be 80% sure that the upper limit of a one-sided 95% confidence interval will exclude a difference in favor of the standard group of more than 10%. The ratio of the sample is 1:1. Risk ratio of acamprosate compared to placebo is 0.14. The sample size calculated with EpiInfo software. Formula used for non-inferiority design with primary outcome as dichotomous variable. An attrition rate of 10% would lead to a sample size of 554, that is 277 in each group. This is the formula used for the sample size, where N is the sample size in each arm. Z1 minus alpha is 1.96 for a 95% confidence interval. Z1 minus beta is a 0.842, that is for a power of 80%. P is 80% or 0.8. 1 minus P is 0.2. And delta is 0.1, the non-inferiority limit. Randomization and allocation concealment will be done using computer-generated random numbers. Central randomization is done, that is in Center A. In case of a new eligible participant, the individual centers will contact Center A and provide the details. The randomization code will be provided and the participant will be treated with the treatment kit, that is either baclofen or acamprosate, labeled with the code. The allocation ratio of 1:1 is maintained across each center. Interventions after detoxification, randomization, and allocation, participants are to receive either baclofen or acamprosate in the kit for the total duration of the study. Participants in the baclofen group will be administered 10 milligram tablets TID for 3 days, and the dose will be increased to 2 10 milligram tablets 3 times a day. Acamprosate will be given at a dose of 333 milligram, 1 tablet thrice daily for 3 days, and then increased to 2 tablets 3 times daily to make it similar to the other group. The medication will be initiated after the detoxification is over. That's about 7 to 10 days after admission. Blinding, double blinding will be done. Both the participants and the investigators will be blinded to the intervention received by the participants in the 2 groups. Informed consent, the participant information sheet will be provided in a language which the participants understand. Informed consent will be taken from the participant after admission for detoxification and before randomization. Ethical considerations, the institutional ethics committee approval will be sought in each of the participating centers. The trial will be registered with the Clinical Trials Registry of India. Coming to the data collection. At the screening stage, capacity will be assessed clinically. The Clinical Institute Withdrawal Assessment for Alcohol Scale will be given to the patients. That is a 10-item scale for measuring alcohol withdrawal symptoms. A complete blood count, a liver function test, a renal function test, serum electrolytes, an ECG, and a CT head will also be done. At the baseline and informed consent, capacity will again be assessed clinically, and socio-demographic data and drinking pattern as part of the proforma will be collected after inclusion into the study to assess the level of uniformity between the treatment groups at baseline. The severity of alcohol dependence questionnaire, that's the SADQ, is a 20-item screening tool, and this will assess the presence and the level of alcohol dependence. The PEN alcohol craving scale is a 5-item questionnaire, and this will assess the craving that the participant has. At follow-up, assessment using the PACS and the GASED will be done fortnightly for first 4 weeks and monthly for the rest of the study period. Telephonic follow-up will be done fortnightly after the first 4 weeks in between the visits. Treatment adherence will be calculated with pill counts at each visit, and general health checkups will be conducted at each visit, that is including vitals and the systems examination. Follow-up, the GSET, that's the generic assessment of side effects, doctor's versions, will rate the intensity of the complaints, various side effects reported by the patients in the last 7 days. Coming to data management, data monitoring and safety board will be established at the coordinating center. Meetings will be held once in 3 months. Is it visible?
Yes, visible, Dr. Smita. Go ahead.
All right. At the screening, we will obtain history. We will do the documentation, do the blood tests, and apply the SIBA AR to see the withdrawal symptoms of the patient. Then the randomization, depending on the inclusion and exclusion criteria, the randomization will occur. The patient will either go into the allocation arm, baclofen arm, or the allocation acamprosate arm. After which a socio-demographic proforma baseline assessments, that is the SADQ and the PACS, will be done. Fortnightly assessments up to 1 month, that is the PACS, the GASED, the pill count, and the general health checkup. After which monthly assessments till the remainder duration, that is 6 months, which will include the PACS, the GASED, the pill count, general health checkup, and along with fortnightly phone assessments to check whether the patient is abstinent, whether the patient has had any relapse, whether the patient has taken the medication, or whether there are any adverse effects. And the end of the study at 6 months, after which analysis of data will be done. Dropouts due to non-adherence to medication and appointments or any severe adverse effects, or participants who relapse met the exclusion criteria are excluded. Okay, this is just a schedule to give us a broad idea where we talk about the enrollment, the allocation, post-allocation visits, that's fortnightly for the first 1 month, monthly for the remainder, telephonic follow-ups, and the closeout at the end of 6 months. Okay, just a quick word on the training aspects. The training aspects will happen at Center A, and they will be trained in the storage of the medication, documentation, filling of case record forms, identification of the codes as part of the randomization, and also the use of rating scales. Coming to our outcomes. So our primary outcome is alcohol relapse, which is defined as a daily alcohol intake of more than 4 drinks or an overall consumption of 14 drinks or more per week during at least 4 weeks. Alcohol lapse is any episode of alcohol consumption not classified as relapse. Our secondary outcome is the craving as measured by a PACS, adverse events as measured by a GASED, and medication adherence measured by pill counts. Our dropouts are if the participant misses 2 consecutive appointments plus or minus 2 days. If the participant misses a single appointment, 3 attempts to contact the participant will be made by telephone. Our endpoints are if the participant relapses, if there is a dropout, or the end of the study, or the development of severe side effects requiring hospitalization. Our statistical analysis plan, all efficacy and safety analysis will be done according to an intention to treat approach that include all randomly assigned participants irrespective of adherence as described in the protocol. Continuous data will be summarized as either means or standard deviations or medians and interquartile ranges, and count data will be summarized as numbers and percentages. All outcomes occurring on or after randomization will be included in the analysis. Kaplan-Meier estimates will be used to generate cumulative risks. Cox proportional hazards models will be used to determine the effects of the intervention on the outcome and to estimate HRs at 95% confidence intervals. The proportion of participants having side effects will be compared using chi-square tests. This is an overview of our budget where we've taken into account the statisticians, training of co-investigator, clerical staff recruitment, medications, both acamprosate and baclofen, travel costs for patients and attenders, blood investigations, salary of research assistants, print and stationery, ethics committee, review during ADRs, insurance, data management services, cost of rating scales, and institutional overhead. Our total budget comes up to 7.88 crores. So our public health message. Addressing excessive alcohol use serves as a low-cost, effective strategy to reduce the burden of disease in low and middle-income countries. If baclofen is shown to be non-inferior to acamprosate, as we hope to do in this trial, it would prove to be a relatively cost-effective, widely available, and easily administered medication in the treatment of alcohol dependence. Thank you.
Right, excellent. So, Dr. Smitha, what you can do is you can go to your cover slide. Just press home. Okay, I'll tell you how to deal with this. And this is useful later on. It's good to learn the skill. Go to your cover slide, click on that, please. Actually, and put it on slideshow. Slideshow. Okay, so right click on your mouse or your trackpad. Okay, and then click on, you don't have that option, it seems. Click on see all slides, the one just above it. See all slides. Oh, it goes to, okay, you don't have, click on that. Let's see what happens. Okay, it goes to slide sorter view. Okay, leave it at that. So leave it at that, and then Okay, whatever you want. No, this is to just make it easy for you.
Leave it at the previous one, sir.
Yeah.
Okay, sorry.
Okay,
Yeah,
so you know your slides, right? You know your slides.
Yeah.
So if people ask you something on sample size, you can jump in there. Somebody asks you on budget, you can jump in there and give more details. All right. So this is group A. Okay, one question from group B. Please note it's a method. It must be a methodological question, something related to the objective, sample size, patients, etc. Not what are the mechanism of action of acamprosate, or this scale is not appropriate. I mean, we can come to scales, which is important, but let's focus on methodology. Okay, group B. Question, please. Please put up your hand with the option below. Raise hand option is there. Group B, quick. You must have your video on. Only then we can see. Okay, Preeti from. I don't know if you have which group you are, Preeti. You have not disclosed your group on the name. I'm presuming your group B. We trust you. So go ahead. Rest of you all, make sure your group name is there. Okay, Preeti. Yes, just a reminder, one crisp question. Try to do it in one sentence, maximum 2 sentences. Go ahead.
My question is for the group A, sir. The question is, how was the randomization done? And the second one is, how was the missing?
No, one question. All your questions of a group A only. Don't need to waste your sentence on that. How was randomization done? Full stop. Answer, please. Other than Smita from group A. Anyone else other than, and Smita will help you with putting up the right slide if necessary. Somebody from group A, quickly put up your hands. Who's got the answer to Preeti? Otherwise, judges are not going to give you marks for answering questions. Endumati, go ahead, Endumati.
Good evening, everyone. It's a central randomization through the coordinating center. Center A will be doing this. Each center will be assessing the participants, and they'll be informing the center so that they will do the computer generated random number. Randomization will be done, and they will be sending back to the center. Thank you.
Okay, fine. Let's ask, and lower your hand. Once you finish answering, lower your hand. Next question from group C, please. Group C, quick. Yes, Dr. Sanjay, go ahead. Unmute, please, Dr. Sanjay.
Yeah, sir. My question is regarding the relapse definition they have given. Generally, relapse is going back to the level of what you.
Okay, Dr. Sanjay, hold on, Dr. Sanjay. We forgotten, so I just waited for who was a previous person, Preeti and Indumati. They didn't follow our rules of communication. Sorry, who's moving this? Is it Smita? Smita, if you do this, it distracts us. So put it on slide sorter view and just click on the slide that you want. Otherwise, it's pretty irritating. We need to learn all these skills. We need to be familiar with that. Yeah, click on the slide that you want. You know your slides. Okay, so Preeti and Indumati, I don't give you marks for appropriate communication. So Dr. Sanjay, do you remember the rules when we did the Zen protocol?
Yes.
Okay. Sir. What are the rules? First, tell us the rules or guidelines, let's put it that way, on communications.
Smita, it was a very good presentation of your protocol. So my question is, the definition of alcohol relapse, I have a problem with that. Can you, you're telling relapse is generally going back to the previous level. Here it is mentioned 14 drinks per or more.
Okay. No, we got it. You don't have to clarify too much.
Yes, sir.
So what is it? So, okay, Smita presented, you can say Smita and group A, well done. But anybody from group A can answer. It need not be, in fact, it should not be Smita because we've heard Smita enough today. We want other people now. Who else from group A? Quick. Who's ready?
Sir, this is Dr. Balasubramaniam from group A, sir.
Excellent. Go ahead.
Good evening, one and all. And good evening, Sanjay, sir. So thank you for the question, sir. And here we gave an operational definition of alcohol relapse, like as a daily alcohol intake of more than 4 drinks, or else with the overall consumption of 14 drinks or more per week during the last 4 weeks. That is the operational definition we are given for assessing the primary outcome, sir.
Thank you.
Thank you, sir.
Okay, excellent. So we have 2 questions coming up from group D, which we will encourage. So judges to please make a note. If you don't agree with any of the answers, either the answer is incomplete or incorrect, any of the two, you have to come and help us and make sure we are getting it right. Okay, so that's a request for our judges, and after which you can, after clarification, you can continue and teach us as well. Right, so Sagar from Group D, go ahead, Dr. Sagar. Unmute, please.
Very excellent presentation, particularly like the minimalistic outlook of the slides. My question is...
Dr. Sagar, you cannot ask your question. You didn't follow the rules.
Sir?
One important rule you didn't follow. See, Smita's feeling so sad. Such a nice name she has, and you didn't even acknowledge her presentation by name.
Oh, while I was speaking, it was on mute. Excellent presentation, Dr. Smita. I'm pretty much impressed by the
team also, right?
Slides. Yes.
Okay. Okay, good. Now proceed to the question.
Thank you, sir. Thank you for that. My question is regarding the dosing frequency and the number of tablets. Acamprosate and the baclofen is quite different. So has care been taken to minimize the bias from the patient side when the patient is taking a different number of...
Okay, got it. We got your question. No need to elaborate too much. Dr. Rajkiran, answer, please.
Thank you, Dr. Sagar, for the question. So we have thought about it, and what we have done is that both the tablets will be looking the same. We will do the modification so it looks the same. And then, so in order to prevent that, that the patient comes to know, so initially we'll be giving TID, 1 tablet, and then 2 tablets TID. So the dose will be adjusted accordingly. So when we are doing the modification of the tablets. Thank you.
Okay, judges, please note the question and the answer. You may want to comment on that later. Okay, last question from Dr. Sri Lakshmi. Oh, Dr. Shalini as well. Oh, okay. Remember, your chance of answering questions is coming next. Okay, never mind. Dr. Sri Lakshmi, go ahead. Dr. Sagar, you can lower your hand.
Excellent presentation, Dr. Smita and Group A, and your teamwork shows very clearly. Congratulations on that. My question to you is, have you accounted for the psychotherapeutic interventions which will affect the relapses and may differ according to centers? Thank you.
Excellent way of asking a question. Answer from Group A. Somebody new, quick. Group A. Where are the others from Group A? Is Dr. Varsha Group A?
Sir, good evening, ma'am.
Dr. Varsha, are you Group A?
Yes, sir. Group A.
Oh, yeah, because I can't see. Okay, Group A. Go ahead, Dr. Varsha.
Thank you, sir. Thank you, ma'am, for the question. Here we have mainly concentrated on the medication part, ma'am. The study and the trial is basically focusing on the medication part. Thank you.
Okay, that's okay. Good. All right, so we've done with the round of questions. Now the turn of our judges, please. Anyone? Dr. Varsha, you can lower your hand. Okay, I'll lower it for you. Okay. Questions from the judges, please. Who would want to jump in? Dr. Vikas, go ahead with one focused question, please. You had unmute to speak.
Yeah. Am I audible?
Yes, very well. Go ahead.
Yeah. Thank you, Dr. Smita and Group A, for an excellent presentation. My question is, you said that the primary analysis will be intention to treat, but you did not define your intention to treat sample. So can you define it?
Okay. Dr. Shiva, go ahead.
Very good evening. Thank you, Dr. Vikas Neman, for the question. I'm sorry, I'm not able to switch on the video as I'm traveling in the car, going back home from work. The question about intention to treat analysis. Yes, I think after allocation and randomization allocation, whoever is allocated in both the arms, they will be taken into account for the end results for the analysis. So the intention to analysis that includes all the participants who are randomized into both the groups. Thank you.
All right, good.
Yeah, I'm Dr. Kauri Devi. Congratulations, yes. Dr. Smita and the group. My question is, you had evaluated by telephone. Is it the same member who evaluated every time, or different people evaluated after 6 months? Sorry, after repeated evaluations you have done. So it's the same person. Why on telephone? Why not in person?
Okay. Dr. Indumati, go ahead, please. You have to unmute. Dr. Indumati, unmute and restart. We didn't hear you at all.
Sorry, sir. Thank you, ma'am, for the question. The same, both will be done by the same person, ma'am. Thank you.
Okay, thank you, Dr. Gauri and Dr. Indumati. Can we ask Dr. Christina, please, for a question?
Thank you for this opportunity. I would also like to congratulate Dr. Smita and Team A, who seem to be working well together. Now, I would like any one of the team members to tell me why they have chosen a non-inferiority design. Non-inferiority.
Yeah, anyone could explain why you chose a non-inferiority design? Do we have some other people from your group? So because you'll get a lot of scores from the judges for new people answering. If the same person is answering, then the judges are not so impressed. Okay, time's up. So Indumati, Dr. Indumati, go ahead.
Ma'am, acamprosate is already proven, but baclofen is yet to be proved. We thought we want to compare whether it is as effective as acamprosate. That's what we thought it is a non-inferiority, or it is equivalent like that. Thank you.
Hold on, I'm making some notes. Give me a few seconds. All right. Right, Dr. Sharma, please, the last question from the judges.
Very nice work by Team A and the group, and well presented by Dr. Smita. I was wondering, why have you chosen an attrition rate of 10% in your study design, whereas you know that attrition rates could be much higher in this particular clinical population?
Okay. Somebody new from Group A for bonus points. Last chance to get bonus points from the judges. I'm reading their minds from here. Group A, new people. Okay, no, not so new people. Please answer quickly, otherwise the time goes off. Dr. Smita, why don't you jump in? Oh, sorry, obviously, if you have the answer, that is why you chose. Yeah, Raj Kiran, go ahead, Raj Kiran.
Sir, good. Thank you, sir, for the question. Based on the previous studies, we have taken it as 10%. Sir. Thank you.
All right, good. So, judges, do you all have another question? I mean, anything else compelling that you think should be clarified or addressed by our participants? Any of the judges, please. We are doing good for time. All right. If not, maybe we'll. Oh, yeah, Dr. Sharma, go ahead, please. Oh, Dr. Christina as well after that. Dr. Sharma, then Dr. Christina. Yeah, sure.
No, Dr. Christina can go first. No problem.
Okay, Dr. Christina.
Okay, thank you. You have said you arrived at an operationalized definition for relapse. Can you tell us the process by which you arrived at this operationalized definition? The process? Was my question clear?
Yeah, operationalized definition for relapse. Dr. Raj Kiran has got the answer. Yeah.
Shall I answer, sir?
Yeah, please go ahead, Dr. Raj Kiran.
Good evening, ma'am. Thank you for the question, ma'am. We have chosen the definition of the relapse based on the Maudsley guidelines, ma'am.
Okay. All right. Thank you for that. Dr. Sharma, last question, please.
Have you tried to do anything to mask the obvious adverse effects of either of those medications when you were administering them, so that the clinician would not know which medicine the person is getting?
Rajkiran, you have an answer for that? Your hand is up.
Yes, sir.
Yeah, go
Thank you,
ahead.
sir, for the question. We haven't done that sort, sir. We haven't checked for that.
Okay. Good.
Is there time for one more clarification?
Sure, Dr. Christina, go ahead. One
Now,
more
in
question.
real life, one of the peculiarities or disadvantages of acamprosate is that you need to take a large number of tablets 3 times daily, which is not so in real life for baclofen. So in acamprosate, one of the problems we get is that unless the patient is very motivated, the 3 times daily. Here, it would seem to me that for the sake of blinding or blinding, you are giving baclofen 3 times daily, therefore artificially, can we say, taking away a real life situation for the trial. Will that affect the result?
Good. Dr. Varsha, do you have an answer for
Good
that?
evening, ma'am. Good evening, ma'am. Thank you for the question. Actually, we wanted to make the pill count and the dosing schedule equal in both groups, that the risk of identification or other sorts of confusion can be sought out. That is why we thought of a different scenario compared to the real life situation, ma'am. Thank you.
All right, good. So we can stop sharing the slides. Maybe I can do it from here. Now, requesting our judges in any order, please come in. This is your opportunity to, appreciate, clarify, and teach in whichever order you want. You can do that. Who would like to go first? Okay, Dr. Vikas is on top of my screen, so I'm going to ask him first. Go ahead, Dr. Vikas.
Yeah, thank you, sir. So I just have a few comments. So building on my question earlier, that how you are defining the ITT sample, I think that's very important that you state it upfront in your protocol. One of the ways in which you can define the ITT sample is, of course, the dictum is once randomized, always analyzed. But in addition, maybe you can also consider adding that they should have taken at least 1 dose of the drug. That will be a value addition to your ITT sample. That didn't figure in the definition that Dr. Shiva Elago said. So I thought maybe this you could consider. And I fully agree with what Sharma sir said, that this is a population where there is a lot of, sir, you can tell me when my time is up, because I have 2-3 comments which I've listed.
Yeah, I think Dr. Vikas, okay, we'll just wait a few seconds. I think there's some delay with his internet.
Is it audible?
Yeah, go ahead, Dr. Vikas. We just lost you for a few seconds. Yeah, go ahead. Yeah.
Okay. So I don't know. I was saying that the ITT sample can be defined in such a way that the patient has taken at least 1 dose of the drug. That is one thing. Second thing, I fully agree with what Sharma sir said, that this is a population where you expect more attrition than 10%. So you also have to plan for a secondary sensitivity analysis where you examine those who have completed the protocol in whatever way you have defined it. Then the other thing that I will suggest is you can consider block randomization in this study for 2 reasons. One is if in case you have to stop the study anytime in between, you still have balanced numbers in between the groups. And secondly, you also have to think about stratifying for severity of dependence, because if you don't do that, you may end up with imbalanced allocation of group severity between group A and group B. So consider stratifying for severity of dependence. That I don't know whether I missed that, but that didn't come anywhere. Thirdly, why don't you also explore the possibility of looking at some biochemical markers of sobriety, like liver enzymes or something like that, which is simple and easy to do and will not cost much, but it will be a good value addition to actually, clinically asking for abstinence and sobriety. Apart from that, you can also biochemically look into that. Then one interesting thing I saw in the budget table was institutional overheads was 2.25 crores. I did not understand how that figure came into calculation. Usually institutional overheads are 5% of the overall budget, even including the number of, centers that you have. I think we need more clarity on how that can come into 2.25 crores. I think funding agency will have their eyebrows raised if they see this figure in the institutional overhead. Maybe Dennis sir can also point out that. One final comment regarding analysis. Before that, there were a lot of concerns about double blinding here. I fully agree that it's going to be very difficult to blind because the side effect profile, somebody who takes baclofen is going to have muscle relaxation, sedation, a lot of different side effect profile compared to what acamprosate has. It's going to be very difficult to maintain blinding. You can actually consider doing this as an open label trial. If that is, there are so many published trials on this group which are also open label. So if that is really proving to be a hassle, you could simplify it that way. Finally, you mentioned risk of relapse as the primary outcome, but it looked like time to relapse was the major outcome because you were mentioning a lot of survival analysis in your primary analysis technique. Even otherwise, time to relapse may be a very good primary indicator of clinical relevance. So maybe you can think about modifying that and think about also using an ANCOVA or a repeated measures ANOVA for testing the effect of intervention on the scale scores. That if you have various continuous scale scores like severity of alcohol dependence, pen alcohol craving scale, and things like that. So that also I didn't see it there. And finally, maybe the routine non-pharmacological interventions like motivational interviewing or the frames model. You could actually have group A where you have frames plus baclofen versus frames plus acamprosate, so that you don't give an impression that you're withholding the normal treatment that usually goes on in all centers. That way you can standardize the non-pharmacological aspect also, which was mentioned by one of the judges as a concern. That's all from my side. So thank you.
Thank you, Dr. Vikas. Those were excellent comments. I just realized we are not recording this. I think it will be a good idea to record. We're getting good inputs from everybody. So, Beena, can you record it for this group?
Sure, sir. I'll switch on the recording.
Yeah. Rajkiran, your time to talk is all over now. You have to sit back, relax, and enjoy yourself and listen to whatever people are saying. We'll follow the rules.
Recording in progress.
Is that okay? Okay, so let's not go back to, I mean, it's okay. Somebody is saying Calcutta is the capital of India. You know better. It's okay. All right. So otherwise, there's no end to this unless, okay. Dr. Sharma, please.
Yeah, actually, the team E raised the very necessary question about other interventions, which I had marked also. And then Dr. Menon has just mentioned this. Probably things like MAT, etc., are standard of care. So you cannot sort of eliminate it. You need to sort of keep place for it in your research design. You cannot say that you did not look for the non-pharmacological interventions, but you can standardize it across your centers. That would have been a good thing to do. In your flow chart, you could probably add one part, which is when is the consenting taken? At what point in your flow chart? I did not see that where the consenting comes. Okay, once you have done a pre-assessment, then probably you do the consenting, and then you go into all the nitty-gritty of your studies. It becomes important as a clinical design and as an ethical principle also. Once again, I would also like to mention the question of the budgeting. I mean, it's a rather a grand budget for a trial which is going to be limited to about 500 people or so. Your funding agencies will find it odd. Your drug expenditure itself is going into some 25 lakhs. I don't understand how that would be possible. Your drug expenditure is more than your labs. So I think maybe a little bit of homework there to see what is the actual lab costs in your institution, and then what is the actual market cost of these medications is what your funding agency will look at. So those things also probably be necessary. But it was obviously a very good team effort and very crisply presented by the original presenter. Thank you very much.
Thank you very much, Dr. Sharma. So let's move on to our next judge. I don't see them on the video. I can only see people whose videos are on. So Dr. Christina, yes.
Yes.
And then finally, Dr. Gauri. Yeah, go ahead, Dr.
Yes.
Christina.
The other judges have given such excellent feedback that my job has been made easier or harder. Difficult to decide what.
You should jump in first. Be the opening batsman always.
Right. I would agree that there is a need for defining treatment as usual if possible. Of course, biases in the other treatments that are given are at least technically meant to be taken care of by randomization. And hopefully that technique will overcome that. I agree it's very difficult to have a treatment as usual across centers with differing resources and protocols in place. Now, the other thing was also about the budget, but I'm a little young to these research things, so I thought this is how things go. But I was glad that the other more experienced judges have seconded my concerns regarding the budget. I think perhaps things need to become a little bit more realistic. Now, as far as the clinical relevance goes, I think it is undoubted that however much we like to wish that we had enough non-pharmacological resources and input, finally in India, in high volume centers, very often it is pharmacology that is relied on, unfortunately I might say, especially for conditions like alcohol dependence syndrome. So the clinical relevance and the research question is definitely there. And I'd also like to congratulate Group A for not only Dr. Smita presenting, but I think most of the members coming in with maybe some members more than others, but most of them making an effort to answer questions. I think one of the problems with RCT, as they say, it's very removed from real life. So when we take away people with impairments in multiple systems, again, generalizability will be weak. And I feel one of the advantages of baclofen is that there are once daily preparations, and that might improve your intake of the drug, and therefore the pharmacological effect will be larger, and that is lost when a person is bound to take baclofen 6 tablets, a day, which doesn't happen in real life at all. So I think this is one of the examples where methodology has superseded practice, what happens in real life, and that is unfortunate. But when you choose an RCT, there's no way around it. Again, congratulations, Group A, and that's it. Thank you.
Thank you very much, Dr. Christina. So you came towards the end and you still had many runs to score. Excellent. Well done. Dr. Gauri Devi, please.
Yeah, the clarification part of it is the centers chosen, I don't know whether they are equally equipped with reference to the resources and the number of cases won. The second is methodologically, I also agree with Dr. Sharma, because the attrition rate is very high with alcoholism. So that is one thing I think you don't need to really take the criteria used to, other centers. I think we need to standardize for our Indian population, one. And the other one is, yeah, I was just wondering whether you can have a kind of pilot study for few cases and look for the attrition rate. And then go ahead, depending upon the results. Maybe that's one thing I felt. Another important thing is coming to the clinical importance. I would say it's very, very good. Because we know poor compliance will be there if there are a number of medication which need to be distributed. So that way, if the outcome is going to be very effective with reference to baclofen, so it's going to be very effective and for prevention of the relapse. And one more thing is, my suggestion is about psychological therapies, psychosocial interventions, because definitely we know that they have the long run, they do have effectiveness along with medication, like in any other conditions that need to be also be taken into consideration. Yeah, on the whole, I think the team has done the methodology, the presentation is good. And I would say three-fourths of the questions were answered pretty well.
Okay, thank you very much, Dr. Gauri Devi. Now, our judges, Dr. Vikas and Dr. Sharma, I can't recall if you all gave some words of appreciation. So if I have some acute dementia, pardon me, but I can recall that the ladies were very forthcoming, and both Dr. Christina and Dr. Gauri were. So gentlemen, please say, give us some, give the team some good, nice pep talk. Yeah, go ahead, Dr. Vikas.
No, I think you missed it. We did appreciate both the teamwork as well as the presenters' crisp slides. All that was done. Yeah, definitely.
From my side, I think I got the order wrong. I appreciated the beginning and then went to the questions. So at the end, I could not. I did not follow your order. But it was a wonderful presentation. It was a very, very good teamwork by Group A.
Okay, so I'm going to come to one of y'all for acute treatment of dementia soon. Okay, acute memory loss. Okay, so I was making lots of notes over here. Okay, I have several points to make. But before that, Dr. Ashok, Dr. Mohan Raj, and Dr. Rema, words of appreciation or anything you want to teach, clarify, please. Dr. Mohan Raj, maybe.
Sir, excellent presentation, sir. Very nice, very crisp, and she touched upon every question that could come up in terms of methodology. Very nice. Nothing more to add.
Thank you, Dr. Mohan Raj. Dr. Rema Shivaram.
Yeah. Okay. Smita, it was a very good presentation, excellent presentation. You have covered almost all the points. And one or two, I think, that came to my mind. Many of these questions were asked by the judges or other your colleagues. And my own doubt was regarding whether the target population you mentioned was the target population or the source population. That was one more of my doubts. Then the randomization question was asked. I think you need to mention something on these ethical considerations in the protocol. That was again mentioned, but it has to be there. That point was missed out anyway. And I think other than that, I think it was a very good presentation. And if you are doing an equivalence trial, and I don't know, in the need and significance part, you have mentioned about why this equivalence trial. And if this is found to be equally effective, what is the advantage and that sort of thing? And I don't remember, maybe as you said, something wrong with my brain. I haven't seen that in the. You might be there, but I haven't seen. Maybe. So that should be there in the background. And other than that, I think many of the issues I thought were already clarified and by the.
Okay. Thank you, Dr. Rema.
Thank you once again for an excellent presentation. Almost every area we have covered.
Right, Dr. Ashok, thoughts from you? Oh, we can't hear you.
Yeah, we are running behind on time, so I'll wait. I'll go with your comments. Good standard set for presentation. Congratulations.
Right, Dr. Ashok, there's some issue with your audio. We barely heard you. Okay, and you also warned me about time. I have several comments to make, and I'm not going to elaborate much. I'm going to do that very, very briefly. Okay, so first a disclaimer. Now, it does not matter who said it, but what was said is what I'm going to address, because I can't remember who said what. I'm not going to say so-and-so said this and this said that. So it's only clarification. And our goal is to learn, right? And no egos anywhere here. Right. Okay. So starting from the research question onwards, and Dr. Smitha, don't share it now, but keep the budget slide ready. I have a quick comment on that a little later on. Okay. Research question overall fine, but somehow it sounds better if you start with the population. Who are you talking about? Among these people with whatever. And continuing on with the eligibility, you said 18 to 60 years old. I don't know why people stop at 60. Life does not stop at 60. Right. So your external validity, are you going to stop there? For people from 61 to onwards, either they don't consume alcohol or there are no trials for them or they don't need treatment. I don't know. So for some reason, people stop at 60. Please do not stop at 60. There are few of us like myself approaching 60 quickly. So please keep trials. So on a serious note, don't have an upper limit of age. There is no rationale for that. Okay, I will not elaborate further. Okay, now your aim overall was fine. Objective, just go back to the slide and see relapse off. We don't know what. You must mention it. You must be able to measure it. You must be very, very clear. Relapse off is not clear. Okay, then rationale for non-inferiority must be stronger. Somebody asked this question. So usually non-inferiority you design for an intervention, drug, device, whatever, an intervention which shows promise, but your standard of care is so good, you are reluctant, you are even worried about going for a superiority trial. You don't want to beat it. You want to say it is no worse than. That is the meaning of a non-inferiority trial. So that rationale must come out very clear. Non-inferiority trials are not easy to design and analyze. And as you would have noticed, your delta is in the denominator, and therefore your sample size is inversely proportional to that. So your sample size increases, right? So keep that in mind. So you must have a very, very strong reason for non-inferiority. Somebody said equivalence. Equivalence is wrong. Do not mention the word equivalence here. Okay, you either do for late phase trials like this, you either do a superiority trial, and when it's a superiority trial, you don't have to mention it. So you only mention non-inferiority. Okay, non-inferiority means no worse than. And you are hoping that your new molecule or a new intervention that you're trying out is going to be not worse than your best available treatment, but it has certain other conveniences. Okay, usually it is adverse effect profile, convenience of taking it, etc. But sometimes it is more expensive, usually more expensive, right? So keep those things in mind. It is not, somebody used the word as good as, I think in one of the responses, as good as is not the right terminology. It's no worse than, non-inferior to. So please keep that in mind. Okay, so you have to give the rationale. You mentioned non-inferiority limit. Usually we say non-inferiority margin, but some people call it non-inferiority limit. It's okay. In one place it was 0.14, in another place you had written it as 0.1. There is a difference between 0.10 and 0.14 when you go to that. When you say 0.1 means it is 0.10. So just go back. Don't worry too much. It's not about, it's just for us to learn as we go along. Okay, there was a comment about keeping it open label. There's a possibility. Just clarify for me, please, which is, are both drugs given 3 times a day, 3 tablets each? Dr. Smitha, could you clarify?
No, sir. Usually acamprosate is given 3 times a day, and baclofen can be given BD, but it has a long, OD preparation, which can be given once a day. Okay, then you're getting into trouble over here if you're going to do it as a double-blind study. Okay, so if one tablet is 3 times a day and the other tablet is once a day, 1 tablet, can you imagine what you got to do? This is 3 tablets 3 times a day, 9 tablets here. So in the other group, you give 1 active tablet and 8 placebo tablets. That is when you can maintain blinding, which is such a complicated thing. It's not impossible to do. You can do it. If your outcome is so important that it needs to be blinded, please go ahead. I mean, if you ask me for a quick advice, in the interest of time, I would say keep it blinded, because your relapse is still a soft outcome. It is not troponins. It is not a myocardial infarction. It is not mortality, right? Or it is not. I mean, most of this. Okay, so keep that in mind. Okay, a few thoughts on the slides. Overall, slides were very, very good, but still can be improved. Remember, we spoke about Kaizen. Anything can be improved. So here are my thoughts to improve it. So firstly, Dr. Smitha, very clear presentation, but I really wish you went a little slower. Okay, the trick is to tell people you have all the time in the world and go. Okay, that is number 1. Number 2, please use a pointer. We don't know where you are talking. Number 3, there were several long sentences. 3-line sentences, 4-line sentences. You don't have to give full grammar, full sentences. Then you end up reading. I've told this repeatedly. So we have to, have good slides, and we have to teach our PG students this afterwards. Okay, that is 1. And the last one is please animate 1 line at a time. If you have 5 lines, 6 lines, we are distracted, right? So how do you hold attention? Pointer and animate. You just hold them to what you're saying. Okay. Okay, ethical issues, ethical considerations you said. Let me say this once again. I'm sure I said it during the session. When you say ethical consideration, there are 2 parts. One is what are the ethical issues?
and how are you dealing with it? What are the usual ethical issues? Okay, it is confidentiality, autonomy. How are you dealing with each of that? Non-maleficence, beneficence, justice, equity. These are the principles. How are these principles being affected anywhere? And how are you dealing with it? Okay, that is one. So these are the ethical issues. We will get informed consent. We'll maintain confidentiality. We'll do this. These are the ethical issues. The other side is ethical procedures. Ethics committee approval we will get here. Okay, and then a quick question. No need of an answer. Do we need DCA approval for this? Answer is no. It is an academic study, right? And you did not mention where are you getting the drugs from? Are you buying it? Is somebody donating it? Or that's important to mention. Okay, and rethink about, do you need treatment for 6 months for this condition? I don't know, right? If it can be shorter, it's even better, but think about it. Okay, there was a question about ITT definition and population. The standard definition is everybody who's randomized is analyzed in the same group as they were. There is something that people write when journals publish called modified ITT. No, it's ITT or per protocol, only one of the two. You can't have something in between. In some situations, people say, particularly if you're looking at efficacy and even more particularly adverse effects of the drugs. How can you talk about adverse effects of drugs if they're not taken even one medication? So you can define your default definition as randomized to that group, irrespective of whether they took any treatment. That is the standard definition, gold standard definition. You can go one step further and say who took at least one dose of either of the drug. That's okay, right? Okay. Then there was a comment, I can't recall who said this, about stratifying for severity of dependence. When you have a large sample like this, my personal thought, respectfully, is not to have any stratification. The moment you stratify, sample sizes get messed up. Then your analysis is also a bit of a challenge. Since you're going to 500 plus, your severity will get balanced out in both groups. Few hundreds of patients will get balanced out. My recommendation, not to stratify. Okay, but on the other hand, you can look into it, look at previous trials. If they had 300, 400, what are the proportion of severity, and you take a call on that. But this is a fairly large trial. Okay, the last point. Two more points on the budgets. Dr. Smitha, please show the budgets. Budgets are really, really important. And whether you get your grant or not depends on, of course, your science, but also how you have written your budget. And just to remind people, as the budgets are coming up, it must be just right. If it's too less, also, the reviewers will think you don't know what you're talking about. You don't know what it costs to do these things. Put it on slideshow, please. Okay. And if it's too much, they will think you're on the greedy side or you're making a fool out of the reviewers. Okay. Dr. Smitha, could you put it on slideshow so we can see it all large? I hope I'm audible. Dr. Smitha, are you there? Oh, no, there only. Okay. Oh, dear. No. Go to slide.
Yes, I'm here. Sorry. My computer is getting a bit stuck.
Okay. No, don't worry. Don't worry. Take your time. No, I was only worried whether my audio went off. Okay. Yeah. Go down. This is really important. So let me spend a minute here. Yeah, there we go. 34. Oh, no, sorry. Okay. Budget. All right. I hope I told you all what are the different categories. I showed you all that Excel spreadsheet. You all recall, or did I not give it to you all? Did I show it to you all? I think I recall showing it to you. But okay, so the first category is salaries. Okay, the second category is your what do you call, all your investigations that you need to do. Okay, then all the other costs for running the trial. Okay, including regulatory, ethics, etc. So put it in different categories. Okay, then even if you did not do that, even if you're presenting it this way, a critical aspect is missing here, which is unit cost and multiplication factor. Statistician, 1.2 lakhs. What, for 1 month you're paying that person? Statistician salaries are 1.2 lakhs, right, per month. So we don't know for how long you're paying. And please keep in mind FTE. You recall I showed you all FTE, that is, right, full-time equivalent. So in other words, a statistician for 1 year, first 3 months, you want to pay them, 25%, 10%. So get used to that. And that is important. Okay. That is one. So for everything we need a unit cost. How much does this unit cost? How many units, right? And what is the multiplication factor as well? Okay. Now Acamprosate 24.9 lakhs. Is it that expensive? 19, I find there is something wrong over here. I'll tell you where there are concerns. Okay, ethics committee, 25 lakhs. How many centers? 5 centers, isn't it? I mean, this
Yes, sir. 5 centers.
I have serious suspicion you're not paying ethics fees, you're bribing people. Okay, it is not ethics fees. Okay, okay. Now, where can ethics fees go up? It goes up when, number one, the fees itself is high. I mean, usually it's somewhere in the 50,000 to 75,000 ballpark. Okay, the initial fees, and then every time there's an adverse effect, and you're reporting adverse effects or protocol modification, there is a modest amount, 5,000, 10,000 they charge, not more than that. Okay, so this is, to put it mildly, where is this 36 lakhs? No, where is it? Ethics committee, 25 lakhs is quite a lot. Insurance, oh my God, you are bribing the insurance people here for 3. Remember, you're paying the premium. Okay, and approximately, depending on the complexity of the trial, the risk of the trial, etc., the premium varies. Roughly speaking, for 1 crore insurance, to get a 1 crore cover, okay, let me put it, to get 1 crore cover, your insurance premium ranges between 1 to 5 lakhs. Okay, so you want 5, somewhere in that range. So that is something seriously wrong over there. And then institutional overhead, so the way to put it is, you show subtotals for each, and then finally in the end, you show the total institutional overhead percentage. It ranges from 2.5 to 15, 20, 25. Okay, if you're Johns Hopkins in Baltimore, USA, it is 45%. Harvard charges 40%. St. John's charges 15 to 20%. Okay, so somewhere in the 10 to 15% range would be, you need to show the percentage. Okay, not, I mean, 2.25 crores is something, I mean, again, you're bribing, you're buying off your institution people. Okay, so now again, look at the total budget. So this budget is somewhere in the 2 to 3 crore range. So there are some serious flaws over here in your estimates, number one, and number two, the categorization and totals are missing, and then the unit and the multiplication factors are missing. I'll stop here, otherwise I can go on and on, but let me, despite all this, whatever comments I gave, all of these comments are not to find fault, it is for our learning. I use this, Kiran, you have your hand up for a long time, your hand will pain. I'll ask you now for a comment. You've been, okay, so let me conclude now quickly for this group. All what I said just now is for our learning. It is not that I'm picking and finding fault. What I want to tell you is, wow, in a few months, you people have decided to, brave enough to go ahead and did a fabulous job. By the way, the judges have all given marks, so they're not going to get influenced by what I'm saying. Fabulous job of designing a non-inferiority trial. And this trial is eminently fundable. If Dr. Vikas Menon, I don't know, just check his pocket. If he's got 4 or 5 crore rupees, I'm sure he's going to give it to you. 7 crores he won't give you. 4 to 5 crores he'll give you right now. But I'm sure the judges are quite impressed, and that's what they said. So this is fundable. My last point is, I'm a happy man. Okay, Rajkiran, since your hand is hurting so much, quick comment.
Sir, I just wanted to clarify regarding the budget, sir. That's it.
You want, doesn't matter, Rajkiran, it's okay. Unless you will not sleep tonight, if you don't get that answer, ask that question. We can give you some Zolpidem. Okay, anyway, go ahead. I'm just joking.
The 10% institution overhead, it is over the whole budget, sir, or I didn't get that point. So that's the reason why it raised to 2.25 crores.
No. So you take salaries, okay? And then it comes up to, let's say, 1 crore. All right, you put a subheading, I mean, subtotal 1 crore. Okay, then medications, so it came to 4.5 lakhs. That's a subheading. Then total is 4.2 crores. 10% of that, 42 lakhs. Okay, 4.2 crores plus 42 lakhs is your grand total. All right, I think I gave you that. Didn't I give you those sheets? I think, and probably I also told you take screenshots of this. This is important. But anyway, I'm happy to send that to you again, which is really important to have. Okay, with this, let's move on to the next group. That was a marathon session, but very well done. Let me repeat what my last sentence over there. I'm a really happy person today after this really superb presentation. Okay, group D now, D as in Delhi. Please share your slides, and your time is going to start in 30 seconds. Who's presenting? Group D, Sagar is presenting. Okay, excellent. Sagar, put it on slideshow and your time starts now. Go ahead, Sagar. We can't hear you if you're speaking.
Just a second.
We can't see you, Sagar. Ah, there you are. There you are. Okay, good, good.
So a warm good evening to one and all. This has been a challenging and amazing experience, and importantly, a fantastic socializing experience. So today I'm presenting on behalf of Group D. I'm Dr. Sagar Garg. The title of our proposal and study is Association of Receptor Gene Polymorphism and Internet Addiction Disorder in University Students, a case control study. This is Group D. So need for the study. Internet addiction is on rage, so to speak. It's an increasing problem, more so in the general population, also in the university students, the future of our race. Prevalence of severe internet addiction disorder is 4 to 6%. However, there is a wide variance in other prevalence estimates where different cutoffs have been used. The wide range is from 0.3, 0.5% to 36 to 40%. And literature on genetic underpinnings of internet addiction is scarce. Our research question is, among university students, what is the association of neurotransmitter receptor gene polymorphisms with and without internet addiction? Our primary objective is to determine the strength of association of acetylcholine, dopamine, and serotonin receptor polymorphisms with internet addiction among university students. And secondary objective is to assess the prevalence of psychiatric morbidity among the participants with and without internet addiction. Methodology, we've been tasked with case control study design. Study setting would be a multi-centric observation study, one center in each South Indian state. Study population would include university students on various streams, that is science, broadly as science, commerce, and arts. Our study duration would be about 3 years. A sampling strategy is multi-stage stratified random sampling. We'll be conducting a pilot study of about 50 samples before undertaking the major study. Sample size calculated based on the previous literature. It comes up to 736, and we have included additional 10% cases, those who refuse consent for genetic analysis, and it comes to a grand total of 810. It was calculated using free software EpiInfo. The power of a study is 80%, and the confidence interval is set at 95% as the norm. Precision is set as 5%. We have considered the prevalence of internet addiction as 4%. This is conservative prevalence. This includes prevalence for severe internet addiction disorders. Eligibility criteria. Inclusion criteria is university students greater than 18 years so that they can consent. They're having access to internet, able to read and write because our self-rated questionnaires are in English, and they agree to provide informed consent. Exclusion criteria is person with sensory motor disability and persons with physical illness interfering with the interviews. Case definition, score of more than 39 on internet addiction test and qualifying for 5 or more criteria on diagnostic interview for internet addiction. Definition of control is score less than 39 on internet addiction test, and these participants are matched for age, gender, and socioeconomic status in a ratio of 1:1 cases to controls. Our recruitment strategy would be as follows. In each center of 5 states of India, South India, we would be looking into 3 different major streams of arts, science, and commerce. Each will have 1:1 division of cases and controls, that is 123 in each group. This is the general flow of our study, where initially university students will be administered Young's internet addiction test with a semi-structured pro forma, collecting the socio-demographic details. More details about it later. And then they'll be administered diagnostic internet addiction interview. Those qualifying this, they'll be further subjected to mini for DSM-5. That will be our inclusion, and they satisfy our exclusion criteria. Then they will be defined as cases and controls. Further, they'll be subject to genetic analysis where an additional consent would be taken, and then subsequent analysis would be considered where presence or absence of genotype. A free written informed consent would be obtained at two instances, one at the point of clinical, one at the point of screening the participant, another at the time of genetic assessment. And participants will have the right to withdraw that consent at any stage of the study. Institutional Ethical Committee approval from each participating center will be taken separately. And ICMR 2017 genetic testing guidelines will be followed. Particularly of interest is the data will be anonymized so that genetic material and the personal details, the socio-demographic details cannot be traced back, and it's going to be kept confidential. And no other genetic analysis would be performed other than the genetic assessment for our study. Various measurement tools that we are going to use to collect the data. One in the university premises is a semi-structured proforma. We'll collect age, sex, socioeconomic status, stream of education, current, past, or family history of psychiatric disorder. Then we screen them with Young's Internet Addiction Test. It is a self-rated test in English. Diagnostic interview is conducted for those who have cut off more than 39. It is clinician administered. Also, we'll be administering Mini 7.02 for DSM-5. Following which, another consent will be taken for collection of buccal swabs, where that sample will be subject for genetic analysis. It will follow these three major steps. Firstly, DNA extraction and purification from the buccal swab, followed by genotyping of the SNPs of interest. Data collection and management. Physical copies of the questionnaires will be stored with the investigators, and the data will be entered in EPI-Info7 for data management, and SPSS version 24 will be used for analysis. Outcomes of the study, the primary outcome would be that the following polymorphisms for acetylcholine receptor, serotonin receptor, and dopamine receptor in that order. I would not read the jargon words there. And another thing is, we'd like to report the prevalence of psychiatric morbidity in both cases and controls. And we are expecting it to be higher among those with internet addiction, in par with existing literature. A statistical analysis plan. The quantitative data will be analyzed by means and measures of dispersion. The difference in socio-demographic and internet use related factors in the two groups will be analyzed using chi-squares, Fisher exact, and independent sample t-test as applicable. Strength of association will be determined by calculating odds ratio. Logistic regression analysis will be done to address the confounding factors. Confounding factors of our interest are presence of psychiatric comorbidity along with internet addiction. We're looking, maybe it could be a dual diagnosis, or it could be in the causal pathway where excessive internet use or internet addiction could be as a consequence of a primary psychiatric diagnosis. We will be conducting an interim analysis that would be planned at the end of 18 months so that we can set our sampling and recruitment on course. Also, we would like to iron out, as I mentioned earlier, any chinks in the data collection and the analysis part by doing a pilot study earlier. This is our budget allocation. So salaries amount to 2 crores, permanent equipments of 3 lakhs, supplies and materials for 10 lakhs, travel about 7 lakhs, contingencies 2 lakhs, overhead expenses 12 lakhs, and other expenses miscellaneous we have added as 1 lakh. It would amount to 2 crore 35 lakhs per year. Over 3 years, it would amount to 7 crores. Largely, the internet use for public has given lots of boons, but in the last 20 years, the banes have not been seen. So now psychiatrists and clinicians are identifying diagnosable conditions, more so because there are treatments available. If it is having an underlying neurobiological mechanism similar to substance use disorders, already existing strategies of non-pharmacological and pharmacological treatment could be extended to the behavioral addiction, particularly internet addiction. Our current work will help in understanding the genetic basis and also help in advancing the literature in this regard. Thank you.
Dr. Sagar, Excellent. I was about to ask you that only. So now go to your title slide. Okay, now you figured that out. Good. So that's the way to deal with it. All right. So this is group D. So question from group A now, please. Group A.
So this is Dr. Balasubramanian.
Okay, Dr. Rajkiran's hand was up first. So yeah, put your hand up. Okay, Dr. Raj, yeah, go ahead, Dr. Rajkiran, followed by Dr. Balasubramanian. Yeah.
Good evening, Dr. Sagar. It was a crisp presentation and a very interesting area to consider for the research. My question is whether training and permission to use Mini was considered in the study. Thank you.
Yeah. Other than Dr. Sagar, who would like to answer? Dr. Shalini. Go ahead, Dr. Shalini.
Thank you, Dr. Rajkiran, for that question. Yes, we have considered training for because it will be administered by a clinical psychologist. So they would have already been trained, and we have looked at training those as well.
All right, good. Thank you. Dr. Balasubramanian.
Good evening, Dr. Sagar. It's an excellent presentation. And I would like to ask about this internet addiction test, which is available in English. What's your plan for validation of the scale in various centers in South India? So we plan to do in 4 centers.
Okay, got it. We got your question. Dr. Sri Lakshmi has got the answer. Please unmute Dr. Sri Lakshmi.
Yeah. Thank you, sir, for the question. Therefore, since it is in English, therefore we have in our inclusion criteria specifically included people who can read and write in English. And though it has not been validated in Indian population, we found that it's been extensively used all over India in the various states.
Good, thank you. Who else? Okay. Now that was group A. Group B now. B for Bangalore. Group B. Anybody? Yeah, Dr. Shailesh. Go ahead. Yeah.
Am I audible, sir?
Yes, audible. But if you don't move your phone, it will be useful for us. Otherwise, your image is shaking too much. Just hold it steady, Dr. Shailaja, and speak. Yeah, go ahead.
It was an excellent presentation, Dr. Sagar and team. I just have one doubt regarding the internet addiction test. You have taken the cutoff score of 36 and told like anyone above that score will be considered as a case and below is considered as a control. Do you think like suppose someone who is scoring 35 also will be having some features which are similar to cases? Don't you need, you should take because as I understand all the scores will be like mild, moderate, severe. Don't you think you should take a lesser score for controls? Thank you.
Okay, who's got an answer for that? Somebody new? Where's other people from group D? You get a lot of scores when new people answer. Dr. Ramesh Babu, which group are you, doctor?
Yes, sir, myself.
Your group D?
Group D, yes.
Go ahead, Dr. Ramesh Babu.
Thank you, very good question. Actually, in the previous studies, they have taken cutoff 36. Later on, they extended it to 50 also. So we put that as a cutoff score, only 36 only. Even if the person comes 35, he may come under mild category only. So we don't take such patients, such persons.
Okay, good. Thank you for that. Now group, that was group B, right? Anyone from group C? Question from group C, please. Group C, Dr. Sanjay, you have a question? Yeah, go ahead, Dr. Sanjay.
Thank you, Sagar, for the presentation. At the moment, I don't have any questions. Sir.
Oh, okay. Dr. Rekha, you have a question?
Yes, sir.
Go ahead, please.
Dr. Sagar, it was an excellent
Hold on a second. Hold on 1 second. Somebody's unmuted and there is some background noise there. Okay, go ahead, Dr. Rekha now.
Good evening, Dr. Sagar and team. It was an excellent presentation. The way and the clarity of presentation was very good. And my question to the team is whether mobile addiction is a part of internet addiction in your criteria.
Okay.
Mobile phone addiction.
Okay, good. Dr. Sri Lakshmi, go ahead, please.
Thank you for your question, Dr. Rekha. Internet addiction actually is an umbrella term as it is being defined and includes various forms of internet addiction, including smartphone addiction.
Okay, good. So that was group C, right? So we are done with our round of questions from the participants. Questions from the judges, please.
Group B is there, sir. Group B.
Sorry? Group B we didn't ask, is it? Or B as
E,
in Bangalore, we didn't ask?
E in elephant, sir. E in elephant.
Oh, E as an elephant. Oh dear. Yes, yes. I don't see any E group members here who have their video on. Okay, anyway, please raise your hand and ask a question. Group E. Oh, I missed that last time as well. Group E. I don't see anybody. No questions. Dr. Rajivi, go ahead.
Good evening, sir. Good evening, everyone. That's an excellent presentation, Dr. Sagar and the Group D. So here, why chosen only the age above 18 and the education like university students only? And in that also, the courses they have chosen differently, arts, science, why particularly chosen different courses? Thank you.
Can I answer that question?
Yeah, who's that? Neeraj? Yeah, Dr.
Yes.
Neeraj, go ahead.
One is for considering the feasibility of the study, and also thing is like more than 18 years, they're in university and they'll be able to consent easily. So we thought we'll keep it more than 18 years.
Okay, good.
For second question, can answer, sir. For second question, she asked another question also.
You want to answer? Yes, Dr. Ramesh Babu, go ahead.
She asked another question also, why we have taken different categories of students, science, arts, and those things. We have taken all those categories just to make this study more generalizable. For that, with that intention, we have included different categories of students.
Okay, good. Thank you for your questions and answers. Time for the judges to ask one question each. Please, who'd like to go first? Just jump in. Yeah, go ahead, Dr. Christina.
Shall I go
Yeah,
first?
Please,
Yes.
go ahead.
Can one of the an interesting presentation by Group D? Congratulations. Can one of you tell me in a bit of detail how you will do your sampling? You have mentioned a rather complex sampling technique. How will you go about it exactly? What is the process?
Can I answer that now?
Yeah, go ahead, Dr. Shalini.
We are conducting our studies across 5 states of South India. So by randomly, by random sampling technique, we'll pick a university, and then in the university, it is divided into 3 groups based on the courses, and then proportions would be derived. Equal proportions will be ensured across the groups.
All right, we can come back further. Thank you, Dr. Christina. Dr. Vikas Menon, please.
Yes, so first of all, thank you very much, Dr. Sagar, and your group members for a very good presentation. Very interesting topic. And my question is regarding this, the case definition that you have used. Obviously, what I understood is you're using a 2-step process, the screening followed by diagnosis. So my question is regarding the validity of the screening tool cutoff. Is it validated in the population? The cutoff.
Can I answer that question?
Dr. Sri Lakshmi's hand was up first, if you don't mind. We have some new people, Dr. Ramesh. Go ahead, Dr. Sri Lakshmi.
Sir, this cutoff has been used extensively across studies. Previous studies have used cutoff of, it initially started with a cutoff of 50, which indicates severe addiction. But since they could not find any cases, they had to actually cut down back to 39 once again. Therefore, we are using a cutoff of 39, sir.
Okay, 39. Thank you for that. Dr. Gauri Devi, please. And then finally, Dr. Sharma.
I just want to know about the lower limit. Why did you put it as 18? Because we have seen in pediatric population also, starting from the age of 12 years, the internet addiction. In fact, it's more with young children, 12 years, 14 years, and less than 50. Why did you include?
Can I answer, sir, that question?
Yes, Dr. Ramesh Babu, go ahead.
Thank you, madam. Thank you, madam. We had done through all the literature in the past. In none of those studies, we could find such studies done below 18 years of age. So we could not take in the test group.
Okay. Good. Dr. Sharma, would you like to ask your question, please?
Yeah. This question was partly answered, actually. It's about the Mini, that training will be given, but the issue of patenting of the Mini and what would be done regarding that, because it is bound by patent and you're using it as an important instrument.
Good evening, sir.
Oh, sorry. Yeah, go ahead, Dr. Shalini. Dr. Shalini, go ahead. Your hand is up. Dr. Shalini, do you want to answer that, or anyone else would like to answer? Dr. Shalini, can you hear us?
Yes, sir. Can you hear me? Yes.
Now we can hear you. Go ahead.
Yes. So we've for the copyrighted versions, we have allocated budget and for the screening tools, but many we didn't think of that, sir. We would after you have raised the question, I think we should add it in our budget. Thank you, sir.
Okay, excellent. Good. Now time for our judges to clarify, teach, and appreciate in whatever order you'd like. And who would like to jump in first?
Can I come in, sir?
Please, Doctor. Oh, Dr. Sharma had his hand up first, so if you don't mind,
sure.
we'll Dr. Sharma, yeah, go ahead. Oh, we can't hear you. You're muted, Dr. Sharma.
No, I said let Dr. Menon go first. No problem.
Okay, fine. Dr. Menon, go ahead.
Thank you, Sharma sir. Yeah. So I just have a couple of comments only. First is my concern is regarding, again, I'm going back to the cutoffs question that I raised in the initial round also. So let's consider a person who has a IIT score of 38 and somebody who has an IIT score of 40. Now, according to your definition, the second person would come under cases and the first person would come under controls. But that's an arbitrary distinction. And we know that no screening, here you are using the IIT, you must remember that you're using it as screening test, and that's followed by a diagnostic interview for prediction. So it's a two-step process of defining cases that you have. So there'll always be some false negatives in your screening. So it's a good practice to consider taking a certain proportion of the screen negatives into your second stage of the diagnostic interview. How you do it, that's something that you have to decide in your group, but there'll always, because of this arbitrary cutoff that you have, which is not really validated in the Indian population, you're going to have a lot of people who are going to screen false negatives. No screening test has that much amount of sensitivity, specificity. So that's one point that you have to consider. Second thing, regarding again the use of the scale Mini, nowadays, at least in my experience, we found that they are not going to give any administration free of cost, and they're taking a long time to reply. So you have to factor in the budget table for the Mini administration also. And in the budget table, I also could not find the gene kits that you're going to actually test for the polymorphisms. I couldn't see that in the budget table, or whether you mentioned it under some other heading, it's included. I was not sure. Maybe under supplies and materials. But then I think maybe you can be more specific about it in this. And I think maybe you can add some more covariates here, because you're using a lot of, you're analyzing psychiatric morbidity among those with and without internet addiction. But what about some of the moderating variables like family support, These kind of covariates, if you add, I think you can, because you have a very large sample and a lot of information, but how you're going to make clinical sense of it is also important. So just getting a finding, that psychiatric morbidity is more among this cases group compared to the controls group is unlikely to impress reviewers, because that's already well documented, as Dr. Sagar also said initially. So you have to think how you can add value to the study by adding a little more covariates, maybe something like family support or some other social variables, and see how these are moderating the associations between genotypes and the internet addiction that you're looking. Those are my comments. Thank you so much. Once again, I think it was a very good presentation, very interesting topic, and I think the team has done a lot of effort to get to this point. Congratulations to the team. Thank you.
Thank you, Dr. Vikas. Dr. Sharma, please.
Yeah, thanks for choosing sort of contemporary sort of an issue for your proposal. And Dr. Sagar presented well, and at least some of the team members did answer. There are a couple of issues, especially in genetic studies, that need to be addressed. The choice of the polymorphism. I mean, why should you choose acetylcholine or the whole bag, dopamine, norepinephrine, serotonin? I mean, there should be a little more specificity and logic behind what you're choosing, especially when the current literature is not very helpful. And you can't use a shotgun sort of a methodology of choosing the polymorphism. So a little more work in this area might help you focus down to one or two limited sort of explorations rather than this huge thing. And then your exclusion criteria probably, I think, need to be a little more specific. Mini has been addressed. There was this question of the sample population. And you said 123, 123, 123, if I remember the numbers correctly, from commerce, science, and arts. The problem is when you said proportional, but you're giving the same numbers from each. How do you know that arts has the same number of students as science has the same number of students as commerce? Maybe science has 1,000, arts has 500, commerce has 1,500, but you're choosing the same 123 from each of them. If that is the case, then it is not a proportional sort of representation that you are achieving. I don't know whether it will make a difference ultimately, but you may need to consider that. And then once again, there is probably, maybe because youngsters and stuff like that, the 7 crore budget has come back again to haunt us. Despite the fact that you will do genetic analysis, I think that is probably some sort of an overestimate. And there are some headings which are missing, like ethics committees, fees, and so on and so forth. So the subheadings can be paid attention to. But yeah, it seems like if you could get the actual cost of the kits and so on, you will have a more realistic budgeting. Having said that, I think it's been a good effort. Thank you very much.
Thank you, Dr. Sharma. Dr. Gauri Devi, please. You're on mute. Dr. Gauri, you're on mute, please. Oh, your video's gone now. Okay, yeah, no, we can see you. We can see you. I'm sorry. Go ahead.
Okay. It's a very simple presentation. And the only issue is I think it's going to be repetition. I don't want to repeat. I personally feel, again, it's a validation of interview, which need to be done taking our population into consideration, though it's done in the country in various parts. That's one. And mini is already being discussed. And another important thing which I was just thinking about is cost effectiveness and feasibility of doing this genotyping. See, the implications when you look at it, are we going to make use of it in day-to-day practice? That is very important because how many centers are there to do genotyping? And if you look at the country as such, maybe in few metros you have, but otherwise not in cities. So that's another thing. Clinical implications, I am not really convinced this genotopic. It's more of academic exercise and just to say. Another important thing is dopamine and serotonin are being more implicated than acetylcholine. So as Dr. Sharma said it, trying to implicate and studying it, it becomes more, difficult, I would say. And on the whole, the idea is good, like in a research point of view, but how effective it's going to be in treatment, in the clinical implications. Another important thing is, as a child psychiatrist, I've been seeing children from the age of 12 years. In fact, especially the COVID lockdown, and many children, the parents come to me saying that from the age of 12 years to 15 years, it's a maximum. They don't listen, and at least the elders, they are able to listen, but the children, they are not able to. I think whether it is done outside or not, whether it is in the literature or not, I think it would be worthwhile including this population also, at least from the age of 15 years. Because children are exposed to the gadgets, especially computers from the age of 9 years, 10 years. So that's the reason I think it's worthwhile study. On the whole, it's a good idea, I would say, and how feasible and implications, I'm not very sure. Thank you.
Thank you, Dr. Gauri Devi. Dr. Christina. Okay, there you are.
Yes. Yes, again, a very interesting area for study, something that all of us are struggling to understand. So I'm happy that Group D is also trying shall we say, joining in the struggle, so to speak. And the presentation, like I already mentioned, was crisp and good. Now, something about the study, the way it is designed is almost like maybe a cross-sectional study with a quasi-experimental model, because that is where you would, divide a screening scale and do this. Now, I don't know whether the research group, if the diagnostic interview schedule, clinician rated, if I understand correctly, it's a rating scale, it's a diagnostic interview for addiction. Now, I wonder why that is not being used, because that is categorical scale, shall we say, instrument, not even an instrument, a schedule where there is a plus minus diagnosis, and why that is not being used to define a case. So that was my first question. And of course, the other thing can be used as more of a quantitative scale for severity of addiction or and so on. And if there is a problem with resources, an effort to work out the numbers needed, like Dr. Vikas said, to look at the sensitivity and specificity of the screening scale in this population. That is the premise that this is a diagnostic interview of addiction, clinician rated. If that premises is correct, then an effort to do that and then go ahead with a case control study. The other thing was to jump to the exclusion criteria. Now, I know in studies it is easy, this is just an ethical issue. Persons with sensory motor disability are excluded. I might argue that people with sensory motor disability might be prone to internet addiction. Why not? And should they be excluded? Just a question. Now, as far as the mini or whatever diagnostic interview is going to be used, is adult ADHD being looked at? Is something I would, this is something that Indians as such, we don't think of too often, but it could be something that is very much associated with internet use. Some sort of semi-structured interview or scale on social support, social network, real life interpersonal relationships quality is warranted, because we know that this may have an inverse relationship with internet addiction. The ethics part, though it may seem, this is college population who is collecting the data, where are they collecting, how much privacy confidentiality is being given. What do you do when you find somebody is a case? Do you, are there avenues to refer, avenues for help that is accessible? I'm sure all these things may be there in the detailed study. It was not there obviously in the presentation. So that is the ethics part. The budget, I would only like to echo what everybody has said, that it needs a little bit more looking into, so to speak. I understand that this is an unmatched case control study, and I assume that the research team has looked at ways of analyzing an unmatched case control study, which is different from a matched case control study. That's all. And no, that's not all. As far as the relevance of the study, again, it's I would say it's a very brave team that took this on, because it's very difficult to define, and the definitions are changing on the ground, you know, and it's very easy for us to challenge this study, you know, because I don't want the group to get discouraged. It's very easy to challenge because our definitions of internet addiction, what is internet? Is it mobile? Is it a desktop? These are all changing, you know. So maybe when you start the study and when you end the study, shall we say, the definitions and parameters will keep shifting. So this is something I would like to appreciate about this group, to take this up, because there will always be questions regarding the validity of the scale. Is what are we measuring? What should we be looking at, and so on. I also agree with Dr. Sharma that maybe a little bit more focus on the number of genetics tests run may be warranted as possible. I'm not an expert as far as internet addiction and genetics are concerned, but as possible. Thank you. Thank you again.
Right. Thank you, Dr. Christina. Thanks to all the judges. We have just passed 5 minutes from our scheduled time, and I have several inputs to give. But before that, let's ask our other senior faculty here, Dr. Rama, Dr. Ashok.
Yeah, shall I come in?
Yeah, yes, Dr. Rama. Brief comment.
Congratulations, Dr. Sagar, for that good presentation. And then I have only a couple of comments. Many of them the judges have already said. And I have my little bit of reservation regarding the definition of case and controls. Whatever the diagnostic criteria that you put for the cases, it has to be for the control also. So you mentioned, other than this criteria for the cases, one criteria, and the control, said that it's less than 39, and not, you haven't included the other criteria. And again, I have the same reservations that somebody talked about. If you put a cutoff of 139, I think there will be a lot of misclassification. I have that reservation in that aspect also. So your definition, diagnostic criteria should be very definite. And then I think regarding the selection of case and selection of controls, I think I'm a little bit confusion here. Because you have to have how these cases are selected and how controls are selected. So it is not clear. So when you case it, so cases may be few, but controls may be so many. So how will you select your controls? If you select, if your case control ratio is 1:1, how will you select your controls? So that is my one of my questions that you want to ask. Then it is better to give the sample size if you say that some reference, if the exposure prevalence and the controls and all. If you have that, then some reference should be there. Then I think if you are for this particular protocol, I think the exposure variable is phenotyping, and we need a little bit more information on how to measurement of the exposure and how you do it. A little bit more information on that. Then what are the possible confounders or other extraneous variables that you want to include in your study? You may have to mention a few in the protocol. Then for the completion's sake, a word about ethics, of course. Then you mentioned about the matching, age, gender, and socioeconomic status you are matching. So for this age, how are you going to match? Is it an individual matching or is it a group matching? So you have to mention how you are going to match this age.
Dr. Rama, so if you actually tell them what is good to do, age, for this age group, what is it, plus or minus 3 years, 5 years?
Rather than going in for an individual matching, a frequent age plus or minus a particular, if it is an 18-year-old boy, then it's a 16 to 20. So in that way, or it's at least not an exact age.
Yeah, we got it.
Yeah. If it is a narrow age range that you are taking, then it is okay. Individual matching you could do. If your age range is a little bit, it is easy if you go for a plus or minus 1 or something like that. Then I think then it's if it is this matched case control study, I think you can do the appropriate corrections in the logistic regression analysis also. Conditional logistic regression, or I think that's a statistician will be better able to tell you. So these are I think my main doubt is regarding the selection of controls, cases and controls. Cases, it's okay, how you select the controls? I need a little bit more clarity there later.
Thank you, Dr. Rama. You're quite right. The biggest challenge with case control studies is the control. We'll talk about it briefly. Dr. Mohan Raj.
Sir, I methodologically a very sound study and appreciate the group D and Sagar for an excellent presentation. I was only wondering, in an emerging thing like internet addiction, which has multiple dimensions and it's not a homogeneous group, doing genetic polymorphism study, will it throw up any result at all was my, I was wondering. But otherwise, methodology, this is focusing on methodology, excellent work by the team.
Right. Thank you, Dr. Mohan. Dr. Ashok, any quick comments from your side? He's looking at the watch. Okay, is that an indication that I should not give any comments? Or you made time for me?
No, the time is kept for you.
Okay, we can't hear you well. I think still there's some challenge with audio at your end. Okay, here are my thoughts. So I'll hit the big issues. And I also realized an issue about the budgets, which I'll come to towards the end. Okay, so now you're looking at polymorphisms of 3 different receptors. I don't know much about this. Are you interested in one more than the other, or all 3 together is something you need to keep in mind, because your sample size estimation has a bearing on that. Okay, so let me jump straight away to your sample size. Dr. Sagar, if you could go to that quickly, please. So what are we trying to find out? The objective of a case control study design is to determine the strength of association of not just more than one risk factors on the outcome that you're interested in. See, unlike a cohort study, multiple risk factors, you go forward, okay, and you can look at multiple outcomes. I mean, maybe there are some outcomes you're interested in, but multiple outcomes. But here your outcome has already occurred, which is internet addiction, and you have a definition for that, right? Now, what are all the other risk factors you're looking for? Now, the moment you matched, and you have 3 criteria for which you're matched: age, gender, and socioeconomic class. You said is usually socioeconomic strata, right? So you cannot study that because you matched for it. It's the same on both sides. Okay. So what is it that you're looking for? Now your genetic polymorphisms. Okay. Now that is one aspect. Now are you looking at what are the others that you're looking at, right? And those would be your confounders, which you need to look at very carefully. And you would use it in your logistic regression model, right? First, you will look at it in your univariate analysis, then you will look at it in a multivariate analysis. So your outcome, your final thing, you squeeze out your entire case control study design, you get an adjusted odds ratio for risk factor 1, 2, 3, right? Are you looking for polymorphisms for acetylcholine or dopamine, or the third one I can't recall now? Okay, so keep that in mind. Okay, now here is your sample size estimation. Now, why are we looking at precision over here? We are not looking at the prevalence of internet addiction in the community. That's not what you're looking at. You have to go to a previous study wherein you have looked at and found the odds ratios of this particular genetic polymorphism as whatever 1.32, 1.43, 2.1, whatever. So now in your study, and then for this you need to work with a statistician, and this is the key principle. So as I said, I'm looking at the bigger issues in this study now, or in this presentation. Okay, so you have to now determine clinically what is an important odds ratio for you clinically. So let us say 50% increase. That means in cases you have 50% more genetic polymorphism of acetylcholine receptor compared to controls. So 50%, that means 1.5 odds ratio is significant for you. So clinically important also for you. So to determine that, what is your sample size that you need? So that is your approach. It is not precision, right? Now again, here you have confidence interval of 95% and 80% power of the study. Typically power is for RCTs that we are looking at. So relook at it, relook at it, and let's not delve too much into it. Okay, you did mention about multi-stage stratified random sampling, which is right. And again, multiple people said this, and Dr. Rema said this as well. The biggest challenge with case control studies is where and how do you find your controls? So controls must be representative in principles. And I've said this in my lectures to you. Let me emphasize it again. Controls must be representative of the case. The only thing that they are not a case. Now that brings us to case and control definitions. Okay, now I don't know about this IAT scale and what 39 means, etc. Right? However, I would like to ensure that a control is not a case. I have no doubt. So now greater than 39, less than 39. So technically speaking, what is 39.2 versus 38.8? Suppose, so you look at it like that. It's such a small difference, right? So I'm a little worried over here. So don't answer this question. But the key issue is defining your cases and controls. The control must not be a case. That's all I want to say. Okay. So okay, we discussed like now in terms. I mean, multiple people gave feedback about 18 years as the lower cutoff, and Dr. Gauradevi also said wherever I remember, I'll recall people's names. Now we need to look at where is the problem a big problem. Okay, and we need to address questions there. Getting consent is not a big deal. You only have to, so you deal with a big problem. It has got a significant or it's got significance. Let me put it that way. And let me not use statistical significance. Okay, it's got significance. So there we address it. And then all we have to do is get consent from the parents and get assent from the children. So keep that in mind. So deal with the issue, and then we are sorting it out. Okay, now let's come to the public health issue with this. Now, you found that genetic polymorphisms in your acetylcholine receptor is statistically significant, right? I'm taking a pause here deliberately so that the next point, what do we do about it? That is public health significance. I found out there is genetic polymorphism. What can I do about it? Okay. So now, can we look at, I don't know much about this area, not much, I know very little about this area. So I'm just throwing up principles there, try to slot it in the right places where it is useful. So if we find genetic polymorphisms, and if we can detect it early, let us say 6 years, 8 years, before they really, even 6 years, 8 years, people are, that day I saw a 3-year-old cannot have a meal without, having the phone in front. So one side plate, the other side is a phone. Mother gave that. So anyway, so the point I'm trying to make is, you find out something, so what? So what is the question? So to answer the question for public health importance, you must answer, so what? So if you pick it up early, you can say this child has got a tendency to get into internet addiction. Therefore, I'm going to intervene. I'm going to tell the parents, and I'm going to, start other exercises to avoid internet addiction. right? So that's the only thing, because I mean, pretty much we can't do much once polymorphisms are detected. I mean, genetic gene therapy is still in its infancy. That's all I would say. Okay, right. Data. Okay, somewhere there was Dr. Shalini, your hand is up.
I have a doubt to ask, sir. Can I
Shall we
ask
do it
it?
again? Okay.
Yes, sir. Yes, sir.
We'll do it, and I'll finish off this very quickly. Okay. Where was I? I lost track now. Interim analysis. Interim analysis typically are done in randomized controlled trials, long-term studies, large sample sizes, and did I explain to your group? Because I've taken so many different groups lectures, I'm forgetting now. Okay, I did not speak about data safety monitoring board with you people, right? Okay, so interim analysis is done typically in trials to find out, number one reason is safety. Okay, second is efficacy, third is futility. Okay, I'll be very brief here. We can read up later, or another time we can discuss this. So we are looking at data analysis and an expert team of people, which includes very highly experienced statisticians, not necessarily qualified, people looking at unblinded data who determine that your treatment is more harmful, and I have clear evidence for that. They look at it at a very low p-value, okay, not at 0.05, they look at 0.0025 levels. Okay, at that level, if I get clear indication that it is harmful, they stop the trial and not allow you to continue. Second one is for efficacy. If your new treatment is much more efficacious even early on with a lesser sample size itself or lesser follow-up, they'll say, okay, stop the trial, announce the results, and then we use the drug, and then it's unethical therefore for patients to be getting control or placebo. Futility is I don't see any difference between treatment and control, no point in continuing it. So interim analysis is not done in observational studies. And once again, remember that case control study is a one-time study. At one time you're doing, so there's no interim analysis. Okay, let's move on in case there was some confusion there. Regarding slides, I have just two more comments before I tell you something about the budgets. Regarding slides, overall quite good, but personally, I mean, this is my thought. This graphics on the side, I would avoid those, right? And then you can so that you can use more space, you can have larger thing, and again reduce the amount of long sentences that are there, as we can see here itself. And somewhere later on, Dr. Sagar was using the pen for underlining, which is a good thing to do. And again, if you animate, you have that much more attention from your viewers or participants or your listeners. Okay, something about the budgets. Let's go to the budgets, Dr. Sagar. Okay, one is the structure of the budgets and the bottom line, and we also are missing the institutional overhead, which you have to show separately. Okay, now I realize, Dr. Ashok, why our budgets are in this way. It is because after 2 attempts, we did not do the session on budgets and regulatory issues. The very last session that we did, EBM, you recall, we had such a long, Dr. Sagar, if you can stop sharing this, I will just show you, and I'll give you something right now, so that the remaining 3 teams can please, work on a budget in the following manner. So let me share these slides which I have. So if you recall, from 26 September onwards, we are trying to present this regulatory issues and budgets. We did not have time. 26 September, is that when we did EBM? Or we did that later, or third, I can't recall. Anyway, it doesn't matter. So this is what we have, and I can share these slides with you. But let me go down to the budgets. This is what I wanted. So this is about all the regulatory issues, which is good to know, all CTRI, HMSC, and all of that, which we can do later if there is time. And this is a little explanation on the ICMR ad hoc budgets. What are the structure, where to go? Okay. This is what I'll put it on slideshow, and I'm going to request those of you who are interested, particularly the next 3 groups, to take a screenshot. Okay, here goes. So this is the summary budget. Can you see? summary budget, and this is a 5-year. This is actually, this is actually the shell of a budget that I prepared and sent it to a UK agency for funding. We did not get this one, but we got something else. So this is a 5-year. Okay, so there are salaries for collaborators, how we're going to pay, travel, equipment, software, communication, project cost. This is where all your genetic testing and all that will come. Travel is important, monitoring, then subtotal. Then you have a subtotal, then you have institutional overheads, 8%. At the time, St. John's was 8%. Then you have grand total, and then you put it here. So can you, this is my summary page. Then I have detailed discussions for salaries, travel, equipment, other direct costs, project costs, all that. And you link each of these sheets, the bottom line of each of these sheets, to your summary costs over here. This is a summary table. Okay, so let's go to the next one. So this is salary. Can you see this? Principal investigator, co-investigator, base salary, percentage of efforts, number of months, cost for salary. This is for year 1, year 2, year 3. All this is total, and we put it here. Dr. Ashok, you will remember the grant that we wrote. We had this detailed budgeting, and it takes a long time. It takes a very long time to do this. So statistician study. So this is for salary. I hope you got this. This is for travel, airfare, lodging, food costs, number of. So this is for steering committee meetings, and then total per trip and number of persons. So whatever X into whatever number of people, subtotal for this year, then this year, this year. Oh, by the way, I forgot to show you something. Annual increment of 6%. So after you finish first year, whatever total you get here multiplied by 6%, that becomes your total over here. So even for travel, you can have an incremental cost. So this was our meetings in London, and this is telephone, telecommunication, all those details. Unit price. Okay, let's take an example here. Okay, maybe let me go here. Okay, let's say we wanted to buy smartphones. Unit price of a smartphone is 18,000 rupees. How many quantities are? 18,000 rupees into 20. This is my total in period 1. In period 2, I don't need to buy a smartphone, so I put 000 here. Okay, this is Omron device for blood pressure measurement, for example. So here is the other costs, and so on and so forth. The other thing which is important for you all is also writing the budget justification, detailed document. This is how we write. Okay, I'll stop here now, but I hope you all took a screenshot. If you want, I can wait again. If you want to take a screenshot of this, you can take a screenshot of this. This is how we write. And then you can take a screenshot of this. Okay, we'll stop there now. And I'll stop sharing this. Okay, so that's all I have to say now. Once again, I mean, case control. Okay, there are 2 hands up, which I will momentarily clarify for y'all. Okay, we'll do the clarification and then we'll conclude. Yeah, go ahead, Dr. Shalini.
Sir, if there is no previous data available, no case control studies looking at the current research question, and no odds ratio or proportions available, how do we go about calculating the sample size?
Okay, that's a principle. Okay, so first of all, it will take you several hours. It may take you a total of 60, 80, 100, 120 hours to say there is no study done in this area. Okay, because I want to say that because invariably this question comes up and I answer, or rather I give you this additional statement and then I answer the question. So please do a very, very detailed literature review. Okay, before you say there is no study done. Okay, then. Okay, yeah, no case control study design. I mean, study done for that. And assuming you have thought of this question for the very first time in the world ever, then what you do is you look at what is clinically meaningful. So is a 30% increase risk, that means an odds ratio of 1.30. Is that meaningful for you? Talk to people, talk to clinicians who understand, not just internet addiction, but they're not only seeing lots of patients, but also know what an odds ratio increase is meaningful. Okay, so that, and then you go ahead. Remember, it's always sample size estimation. We are estimating it, not actually, you may do mathematical calculation, but it's actually estimating. And then you do that. And then there'll always be discussions. So for you, you try and take a larger or a higher, odds ratio. Therefore, your sample size will be smaller. Okay, Dr. Sagar.
Thank you, sir.
I hope that was useful, Dr. Shalini. Does that make
Yes,
sense?
sir. Yes, sir.
Okay. Okay. Yeah, Dr. Sagar.
So in response to the comment that you made regarding the public health message, so is education or psychoeducating the at-risk group considered as a intervention, also a primordial prevention, and using existing non-pharmacological and pharmacological, extending those treatments already available for substance use disorders or addictions to internet addictions. So per se, intervention word is not used, but in essence, I've covered that.
No, perfectly fine. So my only thing is, once you pick up this genetic polymorphism, what do we do about it? Because at 39, which is already, you defined it as addiction. My thing is, what can we do about it? So what would have helped is for you to collect other factors, other modifiable risk factors. So that's the thing. Okay, now very, very important thing when we talk about case control studies, when you are looking at the strength of association of risk factors, you categorize them into modifiable and non-modifiable. All my research, as you all know very well, is in cardiovascular disease. Age and gender, you can do nothing about it. Okay, but very high risk for that. But there are modifiable risk factors. You identify them early, you can modify them. Okay, so that's the thing I was trying to make out. So where your study will have additional value, Dr. Sagar and team, is which are the other important confounding factors which can be modified that you want to identify. Okay, so that's the thing. All right, Dr. Ashok, we can close now. But my last comment over here is, wow, as always, we go to 2.5 hours, whatever said and done. Okay, so exactly 2.5 hours. It's got a magic number there, that 2.5, 150 minutes we have to be with each other. It is said. So was it said, and so what is written. Okay, so thank you very much, particularly to all the judges. Amazing inputs, very, very useful, very, very practical. I'm sure if you are sitting on some DVT, DST, BIRAC, whatever, screening or evaluation team and a project like this comes, I'm sure you're going to give them those 4 crores and 5, not 7 crores, okay? 4 crores, 5 crores, I'm sure you will get. So on a serious note, really, I mean, many of the fundamental issues you all really picked up. And this is the best part, wherein, we learned something, we have, figured it out. You sat in a group, and then you agreed on certain things, and then you defended your questions really very, very well. And then, and there was a huge amount of value add from the judges as well. So thank you very much. So for me, I'm a happy man that we have identified so many things, and we've learned all this so well. But only thing, the budgets, I think because we tried 2-3 times, but then we didn't have time to present it. But hopefully the screenshots that you took, the remaining 3 teams, please do a good job of it. See, at the end of it, you may have a fantastic question, your methodology is everything, but your budget was somewhere off. Just a little bit too much, just a little bit too less, and then your grant will not get shortlisted. Right, so budgets are really important, and my preceding slides before I go to the Excel sheet says, when do you start working on the budget, with whom you start working with, and how many, we make 35 to 45 drafts of the budget before we get it right. 35 full drafts, not before, and we start along with the research question on this side, budgets on this side. We keep working before we get our things right. Okay, with this, I will stop. It's been a long day. I've had 4 or 5 knocks on my door, people waiting for dinner. I'm sure it's the same in your place as well. Thank you all for your amazing commitment to learn together and enjoying ourselves. Over to you, Dr. Ashok, and thank you once again. Dr. Ashok, we can't hear you.
Can I take over, sir?
Yeah, please, Dr. Indu.
Dear respected faculty members and dear friends,